Hello and welcome to another lecture for Introduction to Psychology. This will be the last lecture for the semester. This lecture we will be finishing up on abnormal psychology, talking about therapies. So we are looking at the treatments for psychological disorders, even though I've talked about many of those, but we're gonna transition into talking about some of the therapy settings and looking at some of those treatments in a little bit more detail. I'm going to go through these slides relatively quick because most of it I've already talked about. Just want to kind of just finish up the semester in a relatively quick format. Okay, so we're going to look at psychotherapy, we're going to look at the history of therapy, we're going to look at some kinds of therapists, the approaches, the settings. We'll look at psychoanalysis very briefly, cognitive therapy, behavioral therapy, cognitive behavioral therapy, you know that's my favorite, go CBT, and then we'll just finish up with biomedical drug therapies. When we are dealing with psychotherapy, we have to look at that there is three basic characteristics to therapy, to any type of therapy. The first is a verbal interaction between the therapist and client. So the client and therapist have to be able to engage verbally or sign language, something like that, but where there is actual language communication. Number two is development of a supportive relationship. So this is what's called the client-therapist relationship. I said before, in psychology, we tend to call the patients clients. We don't like to call them patients, we call them clients, so you'll hear me use that as a term most of the time. In therapy, the therapist needs to develop a client-therapist relationship. This relationship is, in a sense, a way to build trust. The therapist needs to build the client's trust, because if the client doesn't trust the therapist, the client won't open up to the therapist. And when I talk about relationship here, I'm obviously not talking about a sexual relationship. That is completely unethical, against all the rules out there. And I'm not even talking about a close friendship, because that's actually unethical as well. When I'm talking about a relationship here is a relationship of trust, a relationship in which the client trusts the therapist and feels close and associated enough with the therapist that they are willing to open up. And then finally, an analysis of the client's experiences and suggested ways for the client to deal with and overcome the problems. When we look at a brief historical background of psychotherapy, we have to talk about how from the 14 to 1700s, people who were diagnosed as schizophrenics today would have been considered insane, lunatics, institutionalized. You've even got they would have been strapped down to chairs, boxes put on their heads, all different kinds of things that essentially would have been ways in which they were taken out of society and they were institutionalized. Then in the early 1900s, moral therapy started to arise. This is where the individuals running the institutions were actually more concerned now, or started to, not necessarily more, but started to be concerned about humane treatment in a relaxed environment. Helpful. This was abandoned in the late 1800s because there wasn't enough information on how to treat people. There was still a lot of individuals who were violent or were not able to function. Plus, the one main issue is this took a lot of work and it took a lot of space to do. So it became, again, easiest just to institutionalize, just to pack in as many people who were insane. And again, insane is different today, but then people who would have been considered insane, people who had psychological disorders, pack them into one place. In the early 1950s, This wretched conditions and inhumane treatment persisted. However, in the mid-1950s, two big changes happened. Antipsychotic drugs were discovered, and community mental health centers were developed. So in the mid-1950s, there became this strong focus on treating individuals with disorders rather than locking them away. What are community health centers? These are areas of low cost or free mental health care that are offered to members of a community, and they provide, in a sense, briefer forms of therapy that's needed in emergencies, and they focus more on the early detection and prevention of psychological problems rather than just the treatment and locking away people with them. And what ended up happening is what's referred to as deinstitutionalization. This is where mental patients from many hospitals were returned to the community, and this had many beneficial things. A lot of people who were institutionalized that shouldn't have been were now let free and were returned to society. A lot of people who had treatable things were now able to be treated at these community mental health centers and were able to lead normal lives. However, this overwhelmed the community mental health centers, as well as you had those individuals who still, even with that help, couldn't function in society. And we had this deinstitutionalization, so all the asylums were closed down, so these people had nowhere to go now. So there was some definite huge benefits to deinstitutionalization, but don't be under the impression that it was all sunshine and rainbows. There was definitely some problems with it that has led to more modern practices where we understand that we still need mental institutions for some individuals. Let's look at the different kinds of therapists that are out there. First, you have psychiatrists. I've talked about this before. Individuals that go to medical school, they get a medical degree, then take a psychiatric residency. And they basically, there's a lot of focus here on the same way we treat physical disorders, that is, brief interactions and then some type of medication or therapy to fix it. Not all psychiatrists are like this, but many psychiatrists will see patient after patient after patient and don't have time for individual patients to do the types of therapy that I've been talking about. Then you get clinical psychologists. These are individuals who go to graduate school for clinical psychology. They earn a PsyD, PhD, EdD. Typically what you're going to get here is a PhD. You'll get some PsyDs. The +1 work in applied clinical setting, that is not true. Most people that are clinical psychologists get 2 years of clinical now before they become clinical psychologists themselves. So there's lots of hours you have to do even before that 2 years, and then you get 2 years of applied work in a clinical setting while you're supervised before you can work on your own. Difference between PhD and PsyD is just in the degree you get. A PhD is a research degree, a PsyD is a non-research degree. So schools that offer PsyDs are offering a clinical psychology degree that does not involve any research along the way. There's benefits and drawbacks to that. Benefits are it tends to be quicker. Drawbacks is you don't get the same level of understanding of science. And one other thing to talk about with PsyDs is the majority of PsyD programs out there are at for-profit institutions. And that means that people are paying a lot more to get these, and these institutions are willing to admit way more individuals because they're for-profit. So you get 100 people in a class for PsyD, an annual class for a PsyD, whereas you might only have 10 in an annual class for a PhD at a similar comparable university. There are some PsyD programs out there that are at private or public schools that are not for profit, but that is actually rare that is the exceptions, not the rule. The final is counseling psychologists. These are people who go to graduate school in psychology or education and earn a doctorate degree in the same things, and then do a year work in counseling settings. Counseling, big difference between the two is between a counseling and a clinical psychologist, and this would be a good one for me to put on the weekly quiz. Big difference between clinical and counseling psychologists is a counseling psychologist tends to focus on more of the minor issues, whereas a clinical psychologist tends to focus on more of the major issues. So counseling might counsel people in how to deal with relationship problems or how to deal with identity problems, stuff like that. Clinical might deal with major depression, schizophrenia, those types of things. Let's look at the different approaches real quick. Insight therapy, we've already talked about these before, so I'm just going to go through them real quick. This is where therapists and clients talk about the client's symptoms and problems. The goal is reaching and identifying the cause of the problem. CBT, cognitive behavioral therapy, we're identifying specific thoughts and behaviors that need to be changed, as well as providing techniques based on learning principles to make the desired changes. So mixing cognitive and behavioral. And then biomedical is use of interventions of biological factors, so drugs, basically. When we're dealing with therapy, there are some common factors, and I already talked about these briefly on the one of the early slides. Just want to kind of go over these again because they're important. That is, in all different types of therapies, there's two main things that need to occur. The first is that you need the therapist and the client. The therapist needs to develop a trusting relationship with the client so that the client trusts them enough to listen to what they're saying and open up to them. And through that, and related to that, the therapist needs to have an accepting atmosphere. If you are judgmental of the client, if you are closed off to the client's way of thinking, to the client's perspective, then the client isn't going to open up to you. There's some different types of therapy settings. When we're talking about therapy, you can have an individual therapy, obviously, but you can also have group therapy. So this is therapy conducted in a group setting. Why is this so common? It's because of a couple different things. Group therapy works good in the fact that the therapist doesn't have to dedicate as much time to one individual, can dedicate it to the group. But also people do really well when they are put in situations where they're interacting with other people who are going through the same thing they are. So if you have an issue, if you are interacting with another person who has the same issue, and maybe they're a little bit more along with the issue and they can help you. You're maybe a little bit more along than the issue than somebody else and you can help them, that type of thing. So it's a situation where you can receive feedback from the group and the therapist. Family therapy, or when all family members, designed to just reduce destructive relationships and improve communication. Couples therapy, pretty self-explanatory, improving communication and conflict resolution skills in couples. Okay, let's go through some of these perspectives real quick. I already talked about them earlier in the semester. I just kind of want to finish them out now, not just looking at their research perspective, but their therapy perspective. So psychoanalysis, I'm not a fan. It focuses on the idea that we have the unconscious parts of our brain, these hidden or repressed feelings, and that they're dangerous, they're threatening, and that these unconscious conflicts are the main reason for the development of psychological problems and physical symptoms. And the techniques used in psychoanalysis are free association, dream interpretation, and analysis of slips of the tongue. All things that don't have any support by the research. And one thing that's big in psychoanalysis is transference. That's where the patient reacts to the therapist as a substitute parent, lover, sibling, or friend and projects strong emotions onto the therapist. And again, the evaluation of this, it's really declined in popularity because it's just not supported by the research. The competing therapies work so much better, and once psychoactive drugs came about, they even work better. Even though I'm not a big fan of the psychoactive drugs, except in a very few specific circumstances, they are better than psychoanalysis, which says something about psychoanalysis. Client-centered therapy, on the other hand, is person-centered therapy. It assumes that each person has an actualizing tendency to develop one's full potential. This positive psychology, where a therapist's task is to show unconditioned positive regard, show compassion, empathy, caring, respect, all of these. And as I had said before, these are earlier in the semester, these work better for when directed at minor issues in life, stress, anxiety, but not the full-on disorders. The next is cognitive therapy. I've talked about this some, but cognitive therapy assumes we have negative thoughts that are going on in our mind without even really realizing it. They're subconscious most of the time. And by repeating these automatic negative thoughts, it distorts how we perceive ourselves and the world, and influences how we behave and feel. And this, as I said before, things like rumination, things that drag us down. It's just this negative thinking, this negative processing, negative associations we have in our brain, all of these things. And cognitive therapy seeks to break these negative associations, these negative thinking. Behavioral therapy, on the other hand, as a separate thing from cognitive, is where we look at modifying behaviors using conditioning. So we use classical and operant conditioning to change behaviors and improve functioning. Reinforcement, punishment, pairing, so the classical conditioning. So we change behaviors rather than the underlying mental events. So cognitive is more focused on changing the mental side. Behavioral therapy is focused on changing the behavioral side. One of the most common things with behavioral therapy is systematic desensitization. I talked about this before, but this is that technique of which you're gradually exposed to something and you practice relaxation at the same time. Then we merge those together, because really there's a while where cognitive therapy was popular, a while for behavioral therapy was popular. What it turns out is merging those two together is the most effective for treating most psychological disorders. So this combines cognitive and behavioral, so it focuses on changing the negative thinking as well as changing the maladaptive or disruptive behaviors. So the cognitive and behavioral sides are worked together. You change the negative thinking as well as changing the negative behaviors, and you get positive outcomes. For most psychological disorders, a modified version of CBT, modified for that disorder, a modified version of CBT has been shown to be the best treatment. So treating the negative cognitions as well as the negative behaviors is, for most disorders, has the best both short-term and long-term outcomes. And then the final thing is just the drugs. We talked about those a bit. Antidepressants, anti-anxiety drugs, the mood stabilizers, the antipsychotics. There are specific situations where these are the only treatments, such as like with schizophrenia or bipolar. There are other times where these treatments, like antidepressants, are overprescribed, where other things work just as well or better, especially since every one of these has negative side effects. And again, this is just up to the psychiatrist, and now some psychologists have the ability to prescribe drugs, but this is up to the person who's prescribing on whether it is justified in prescribing or not. And I do feel sorry for some psychiatrists who work at a hospital where they basically have 8 minutes to see a client, 8 minutes to see a patient, and then they've got to see someone else that have to make money. And it's just really unfortunate that when you only have 8 minutes, 10 minutes to see someone, you're of course going to jump right on the quick treatment. The quick treatment is drugs. Write a prescription, move on. That's the one drawback to behavioral therapy, CBT, cognitive behavioral therapies, and client-centered therapies is they take time and they take effort. It isn't something that the person can just come in once and be done. No, they might have to come in once a week for a while, and then down to once a month, and then still maybe have to come in once every 6 months or so, just to keep it going. Whereas the biomedical, it's one and done quite often. Okay, but that's it for this. We talked about psychotherapy, we looked at the history, talked about some kinds of therapists, approaches, settings. Then we went through the different things, psychoanalysts and how it's fallen out of favor, even though some psychologists still practice it. And then we looked at cognitive, then behavioral, then combined therapy, as well as some of the biological, biomedical treatments. All right, that's it for this semester. Thank you. It's been a quick one. I hope the recordings of the lectures have helped you out. Be sure to go and do a review, do a teaching evaluation. You should have the codes for that. I really recommend going and doing that. It really helps me out. And any recommendations you have, I welcome. Any encouragement or praise you have, I also welcome. I'm not going to say I'm not going to welcome that, but I do appreciate both the positive and the negative, because I do want to know what I can change, but I also want to know what you liked, because that's the things that I can continue to use. Switching to online has been a rough thing. It's been difficult for all of us, but hopefully moving forward, this helped you learn a lot. I really hope that you learned a lot this semester. You can tell I'm passionate about psychology, and I love talking about psychology, so I hope I stirred some passion in some of you. Thanks.